Good afternoon, everyone. So, uh, from morning we started treating the primary. Now we have moved to treating the secondaries. How it is impacting the survival and quality of life to a prostate cancer, we are going to see. So this is the topic. We'll come to later. So what NCCN has to say when we start treating with oligometastatic or limited metastatic disease, they say you go ahead with the biopsy of the secondary lesion, do all the mutation testing, including MSI, TMB, and HRR. And if you found out to be positive, you go ahead with treating with ADT. There is no role of radiation upfront. Then bone anti-resorptive therapy. There is a line written palliative RT for painful bone metastasis. So you have to wait to treat these patients until they become symptomatic, or best supportive care. So radiation therapy to the secondary has written just above the best supportive care. And if you find this, you go ahead, but depending upon the biopsy, you go ahead with systemic therapy. But if you go ahead with in detail, they have written that in a patient with limited metastatic disease, that oligometastatic, ablation is the goal. You can go ahead with SBRT. How and other in a patient with limited progression or oligoprogression, limited residual disease or otherwise effective systemic therapy, you can also go ahead with SBRT. So taking these into background, we'll move over to our abstract, that is stereotactic SBRT and abiraterone acetate in patient with oligometastatic disease upfront without any previous treatment. So it was a Italy-based trial, and from 16 centers, they have took around 157 patients enrolled between January 2019 to September 2022. They were metastatic CRPC with 3 or fewer bone or node disease. It was a multi-center phase 2 trial, adding SBRT to all site of metastatic disease in addition to abiraterone acetate and prednisone, as we start usually. And how they defined metastatic CRPC, oligometastatic CRPC, less than 3 non-visceral metastatic lesion. No previous treatment was allowed. Patient with visceral metastasis was excluded. And you start with abiraterone acetate and prednisone, and after a month, within a period of 3 to 4 days plus minus, they started doing SBRT to all the metastatic sites. This was the baseline population feature, which was well managed in both the arms. The only thing, if you see the number of patients who has more than one bone metastasis, was around 70% in the abiraterone only arm, that is control arm, and it was only nearly 55% in the abiraterone plus SBRT arm. The primary endpoint was biochemical response, defined as a PSA decreased more than 50% at 6 months, and the secondary endpoint were complete biochemical response and progression-free survival. Complete biochemical response was defined as PSA less than 0.2. Now, this was the trial design that took around 157 patients. 82 patients were randomly assigned to receive only abiraterone acetate, and 75 patients were abiraterone acetate along with SBRT to all the metastatic sites. One patient after enrollment denied, so he received only abiraterone acetate. Abiraterone acetate was given in usual doses, not the reduced doses, that is 1000 mg, along with a standard dose of prednisolone. And the SBRT was given in different fractionation and schedule. 2 patients received single fraction RT of 16 gray, but majority of the patient received somewhere between 27 to 40 gray in 3 to 5 fractions. And what were the result? The biochemical response was seen in around 80% of the patient, and surprisingly 92% of the patient in the experimental arm versus 70% of the patient in the control arm. Complete biochemical response was seen in approximately half of those patients, nearly 40% of the patient. They did a univariate and multivariate analysis. In univariate, both the treatment and baseline PSA was significant, but on multivariate analysis, what they found is that only the treatment is statistically significant. So after a median follow-up of around 25 months with an interquartile range of 17 to 36 months, approximately 75% of the patient shows progression, in which approximately 30%, nearly 22%, nearly 30% in the experimental arm versus 53% in the control arm. Median OS was not reached. Median PFS was 17 months in the control arm and not reached in experimental arm. Now, biochemical progression as the first site was seen in 36 patients, and radiological progression as the first event in 39 patients. So here we note that if we follow these patients with only PSA value, we might miss these 39 patients on the first progression. The median biochemical and radiological progression-free survival was 36 and 34 months in the control arm, and it was not reached in the experimental arm. The median time for subsequent treatment was 36 months versus 18 months. So we can take patient on the same systemic therapy for more than 1.5 years if we add SBRT from the very initial of the treatment. Over a period of this, around 24 patients died, of which 9 patients was in the experimental arm and 15 patients in the control arm. This was the chart analysis, and both this biochemical progression-free survival, radiological progression-free survival, and freedom from next line of that is NEST, they all were statistically significant. What was the safety profile? It was if you see, there was no grade 3 toxicity. It was only grade 1 and grade 2 toxicity. Only thing which I couldn't find is that the cardiovascular disorders were found in around 15% of the patient in the arm where only Abiraterone Acetate were given. This might be a biasing. I don't know. I couldn't find a reason for that. This is just an observation. So it is the one of its first randomized prospective clinical trial to compare first-line systemic treatment alone or with SBRT. What they found, addition of SBRT to first-line treatment, including Abiraterone Acetate and prednisolone, yielded a significant increase in 6-month biochemical response and complete biochemical response. Median PFS, as we have seen, it was 17 months, which was comparable to other trials of the same design. Timing of SBRT in addition to the standard systemic treatment is an important factor. Moving on to the next abstract, that is progression-directed therapy in oligoprogressive castrate-refractory prostate cancer. So the previous one was start adding the SBRT from the very beginning. In this case, adding SBRT on progression. So what they hypothesize is that the progression-directed therapy treating oligoprogressive lesion might differ next. And why it will differ next? Because in oligoprogression, only a certain percentage of the cells are resistant. Most of the cells are still sensitive to the current therapy that is going on. So if you change the disease and if you change the therapy and take another therapy that might be less sensitive to the current disease. How they define oligoprogression? Same, up to or less than 3 metastases. They found they try to see whether PDT could postpone NEST, that is next line of systemic treatment, in patient with oligoprogressive metastatic CRPC, MEDCARE Trial. And that on treatment, patient, when the accrual was done, the patient was either on ADT or ADT plus an androgen receptor targeted agent. Progression was detected with conventional imaging, that is bone scan, CT, and MRI. PET scan was not included in this study. Docetaxel treatment was allowed. All progressive lesion has to be treated with progression-directed therapy, either SBRT or metastatectomy. Repeated PDT was allowed. Once it has progressed in the site of prior SBRT, repeated SBRT was done. Primary endpoint was NEST-free survival, and there were 4 secondary endpoints: clinical progression-free survival, prostate cancer-specific survival, OS, and toxicities. It was done for a period of 1 year between January 2020 and January 2021. 20 patients were included. Median age was 74, median PSA level 4, and median PSA doubling time was around 4 months. Median follow-up after 28 months, what they found is that total 31 lesions were treated, somewhere between 20.5 to 30 gray in 3 to 5 fraction. At the time of accrual, 16 patients were having bone metastasis, 2 patients had only lymph node metastasis, and each patient has liver metastasis and local recurrence. At the time of accrual, around 8 patients were having only ADT and 12 patients were receiving ADT plus ARTA. They found out that median NEST-free survival was approximately 17 months. Like we have previously seen in previous abstract, that it was changed from 18 to 36 months. So around 1.5 years of NEST-free survival you can get. The median clinical progression-free survival was 6 months, and median prostate cancer specific survival was not reached, while the median OS was 29 months. 9 patients died, in which 3 patients died due to a rapidly progressive second primary, including small cell lung cancer, leiomyosarcoma, and AML. PDT was well tolerated with no acute nor late grade 3 or more toxicities. There are other prospective studies also that has shown similar kind of results. And lastly, as in the previous speaker has told, we are not the only one who are targeting these lesions. Nuclear medicine department and nuclear medicine physician are also targeting these lesions. And we have seen that this bullseye trial and the lutetium-4 trial, that is PSMA-4 trial, they are also targeting these kind of lesions. So in a nutshell, if we talk about treating the oligometastatic disease, not only the primary, but if you focus on the secondaries, that will have an impact of around 1.5 months of the 1.5 year of the nest-free survival. Thank you.